Hello, welcome to the final episode in this progressive MS webinar series this should have ended actually in 2021. But today we're going to be talking with Dr. Jonathan Egan about relationships. And as customary, I like to give a little bit of a bio on the speakers that we have. So Dr. Jonathan Egan is an academic and chartered health and clinical psychologist. He has also trained in both attachment and affect phobia therapies. His research has been in relation to trauma, its effect on a person's psychological well-being. His other clinical and research interest is in how our own learned internal models of relationships, which we learn in childhood, can affect both professional caregivers and in people who are diagnosed with chronic health conditions, and whether they can learn to improve their ability to seek help effectively without shame in order to receive effective care and to be met as a person who is an expert by experience in their own health status and needs. So very welcome, Jonathan. How are you feeling?
Not too bad, considering I've had COVID, and the whole family have COVID since Friday, and it's really not a good thing to get. It affects everything from your throat to your eyes, to your body, to your breath, to nausea, to vomiting, and it's really quite I think the government must be downplaying it to some degree, because certainly what I have is something that I'm on antibiotics now, so I haven't slept in a few nights, but it's not something with any I have underlying kind of brittle asthma. Anyone with an underlying health condition should not be getting this.
And I'm delighted that you mentioned this, Jonathan, because this is a continuing pressure that we have in Ireland. And in some respects, because this webinar is about relationships, it actually affects our relationships too, depending on, and this is something that I wanted to discuss perhaps later in what we're talking about, if you have a relationship with somebody that doesn't agree with your viewpoint on certain aspects. And okay. I don't want to just focus on the COVID thing, but maybe other things like finances or lifestyle.
Yeah.
So in this webinar, there's a couple of things that I think we should cover. The first is your relationship with your spouse, partner, boyfriend, girlfriend, whoever that is, your family relations, your relationship with friends, and if we get time towards the end, we might include a bit on work.
Brilliant.
So relationships is such a broad topic, and I know myself in how I've lived my MS. It has been really important, in fact, pivotal to me, how I manage this illness, the relationships that I have with various different people.
Yeah.
Is there a reason for that, Jonathan? Can we do this on our own, or do we actually need to work with other people?
One of the best ways to calm your fear system is to look in the eyes of a person who you trust and understands you. So yes, however, it depends on how we bring along our MS or our conditions as a hidden thing or an open out in front thing that doesn't define us, but it is a fact of life. It's hugely important. How you relate to others is often learned in the home, at school, and I find it takes you about 25, 26 before you can start initially reevaluating your friendships and who is good enough for you and who you, around that age, 23 to 26, we do that first of all. But then in our 40s and 50s, we then again become more discerning. Well, hopefully we become more discerning of knowing who not to go to with concerns about your health or looking for help. The person who you can go to and they can listen to you, but who won't give their tuppence in about, oh, and do you hear about me? Or the person who just talks at you, who has MS like you, but just talks about their MS, and it's like an autistic conversation. It's a one-way street, and you're waiting for your own voice to get in at some stage. So there's something about the reciprocity. So you and I have good reciprocity, whereas other people might not have. It might be a one-way street. So it's about listening to the to and fro.
And that can be a real challenge depending, and this is where I see, and sorry, if anybody has any questions that they'd like to ask, feel free to put them in the Q&A, and if we can, we will try and address them over the webinar. Given that our illness is getting progressively worse, and we're later in life when you end up having secondary progressive MS, different situation when you're dealing with primary progressive. But you've got this learned behavior that you have over whatever, say you're about 40, 50 when you start getting progressive MS. And you have built up a certain relationship with your partner up until that time. And then the dynamic changes where you end up becoming much more dependent on that other person. And your illness is declining. How do we stop ourselves becoming only focused on ourselves in our relationship? Because I can see that as being damaging, because there's no equality anymore.
Definitely. We know I did a study recently with female stroke survivors, and they found it more difficult than the male stroke survivors, because it actually it gnawed against their own perception of self as caregiver. So for women to be looking for care, they found it more difficult because their role in the house was to be caregiver. So they found it much more difficult than others. But in general, look at in your 40s or 50s, going from an independent, autonomous person with your own self-esteem to suddenly having to, that can be very difficult, particularly for people who've been very active, the boomers, I'd call them, the people who could, do the work of 5 people and been praised for it all their lives. That's going to be 10 times harder for them to slow down and have to be able to ask for help. Is not a natural. They're the people who usually people went to as problem solvers, as the Harvey Keitels of the world, of the people who could manage small corporations, as the man or woman who you'd say they could run a country. Those people find it much more difficult to seek help and use the words of I'm vulnerable, I need help, than a person who has been in that role before. So yes, if a person who much younger starts developing MS and they're say 21, and then going into progressive, might be different than somebody who at the age of 30 started, or 28 started to develop MS and go into progressive then later on. So it does depend on your trajectory as well. But there's something really difficult about saying, I need your help. It's a really difficult thing to ask for.
And I know in my life that has been a challenge for me. And there came a day when I had to make the decision, and it was the day that I decided, or I accepted was the correct word, that I have a disability and that I need to see myself as a disabled person. And that actually liberated me at the time, because then it opened up a whole new range of things that I could do to help myself. But in my relationship, asking for that help is really, really challenging. I know for me it was, because like you said earlier, I was self-sufficient. I was the person who did things. And now I'm the person who has to ask for things. And my concern throughout this has been that dynamic between me and my partner is changing from being, let's say, lovers to being a nurse and a patient. And I think that can be destructive. Am I reading that right?
No, you're completely right. And it's through lived experience. People will be nodding, listening to you. It's painful. And it's almost like it's like a rebirthing process when it happens, because when we get to a place of realizing the reality to ourselves, our body gets very tense, and we get very pain around our throat and our sternum, and that it's a very painful emotional experience. And that painful emotional experience, until we break through it, we won't go anywhere. We'll go in circles. We'll go to our bedroom, we'll go to our bathroom and hide away, or we'll give out and give to other people responsibility. I shouldn't have this MS, or those kind of non-acceptance bits. But when it comes through, there's a great breakthrough. But it's very painful to get to that place. With relationship, the reason why we fall in love in the first place, or we relate well to a person, is often they have a shared interest that you have. That's something that you or I do that makes you attractive. Because when you have an interest, it increases vitality. And I think we're more attracted to people who have more vital energy than people who are morose and who don't have a light in their eyes. Whether that's Stephen Hawkins in a wheelchair versus, if someone is alive at some part of their body or mind or soul, that gives a sense of vitality. Now, and then that vitality often gives us monetary rewards or social rewards, if you're a nun or a priest or something. But that feeds into what we call competence. So for me and you, Robert, we both know it's very important for us to feel competent within ourselves. That competence is then related to our mojo, our libido, and our sexual energy. So we've got shared interests with the people, we often fall in love and have sex. But if one of those pieces go,
yeah,
it's almost like, well, what's happening here? And it's a sense of, if I don't feel energized by myself and my interests, how could I be attracted to this?
Yeah.
My light is gone. I'm not Robert. I'm not Jonathan anymore. I'm not the real Robert, not the real Jonathan. That brings up a really difficult thing, because particularly if you maybe weren't cherished or gotten by one of your parents, or maybe a nasty teacher in the school, the cleverest place that children have to go to when they're not being met is to dissociate. It's to withdraw to the bathroom, to the toilet, to go a bit blank, to gaze out the window, to at a body level feel heavier, for them limbs to stop moving, for your voice not to be able to work. And a lot of these, what we call somatoform dissociation, which is a response to not being met. It's an attachment response to stress. Okay. And there's a thing called the still face, where we get a mother to play with the baby and then look away and they just go, and the fear that rises in the baby, and they scream and shout and move to try and get the attention back from the mother, and the energy, because there's no such thing as a baby or a mother. There's mother and baby, or a father and baby. The fear that rises in a person is almost too overwhelming. So we know in adults, John Gottman studies. John Gottman in the US has a lab where I think he's observed about 700 couples over weeks and months, and discovered those 4 things that can cause absolute, will predict the end of their marriage, the relationship. The first one is having a partner who criticizes you. You're bloody MS. For God's sake, can we not do anything? Is it always going to be getting in the way? Criticism. And what we do to that is we get defensive if someone's like that to us. Okay. And then if the person starts to treat us like contempt, like a subspecies, then what happens is we will then go into stonewalling, which is that defense, which if you get the mother to turn around to the child, it's where we don't listen to the person anymore. We don't attend to them as another human being, and we give up on them. And that causes such emotional upset in the partner, but we all do it to certain degrees. And if you add those 4 together in a relationship, if you want to end a relationship, do them all 4. It's easier to say, sorry, I'm not in love with you anymore. But if you really want to do it in a very disheartening and cruel way, use criticism, contempt, stonewall with a person, and you end up feeling helpless and blame themselves and leave the relationship. So it's something about the opposite of that, which is to listen, to say if you're feeling overwhelmed, hang on, honey, I'm just a bit wrecked. I've got a bit of a flare at the moment. I need to go off for 14 minutes and sleep. You know me, it's the MS is kicking in. It's not you. We're having a difficult conversation. This is really upsetting for me, but I do want to talk about it, and come back 40 minutes later, or do whatever you need to do to reset yourself. Be important.
I've been in that position, Jonathan, where I've had difficult conversations with my partner, or we needed to have one.
Yeah.
And inevitably they seem to happen in the evening time or at nighttime, when I am just exhausted. I actually cannot process what is being said. And then I get angry, and then I explode. And that's really destructive, because my partner, it's not her fault, actually. No. My illness is making me a difficult person to talk to. And what I've said is, sorry, I just can't talk about this now. We need to leave it till tomorrow. And if we can talk about it on our walk tomorrow, much better, because, and I learned that by making the mistake of talking about it at night, and it was a disaster. It was explosive and damaging, really catastrophic.
Yeah. My wife's a morning lark. I'm a night owl. So the worst time to talk to me about anything is when she really wants to talk about something, which is straight in the morning at 6:30 or 5 in the summer. I start to about 11. So there is about it finding a time when it's best kind of common ground for people to talk. And it's about saying, look, this is part of my MS here. You're not making it up. Now, with every illness, whether it's my brittle asthma or something, we can always use the illness as a secondary gain to get out of things. Oh, my, really can't attend that party. Can't do that. No. And we all do that naturally, but it's about being kind of honest to ourselves about when we do and don't use those. The difficulty is then is we stop looking at the person in their eyes. We start going around the kitchen or the house, doing our chores, being busy in the same presence as the person, but we're not present to the person. So we have to be really honest, and we all get into that, to say, okay. And one of the things to do there is to go over and just touch their arm, or just give them a rub, almost like being two dogs in a house. Just to start that relational and a soft rub of the arm, or just a touch in the back or something, in a very gentle way. Says, I love you, I know you're there, in nonverbal. We've probably gone through a difficult time there. And then slowly you start to look in the eyes, and then sometimes a smile occurs. And it appeases our guilt then, but it's a movement, an approach movement, rather than being frozen and arm pulling away. If you notice yourself going into the room more often than you would naturally with your MS or whatever condition a person has, then it could be a defensive maneuver. It means that the anxiety is getting too much, the fatigue is too high. And remember the things which I said about when you're not being met as a person, or you don't feel, the natural thing we all do is to get angry. But if that's not met, then what happens is we go into collapse. And a lot of the things of somatoform collapse mimic MS. Okay. That's where your legs feel heavy, you can't move them, you can't move your arms, you feel like you've no volition, you could lose your voice. You feel numb inside. You feel overwhelmed, you get fibro fog, kind of a fibro fog, but a mental fog, and concentration, they all go as well. You can still hear, but the ability to speak becomes more difficult. So the natural human stress reaction could actually compound the non-myelinated part of the brain in MS as well.
So, and this tells you why relationships are so important to have correct and setting up the right rules within the relationship from the beginning, I think. And this actually goes to one of the questions, the first question that we have here. She would, or he, I don't know whether it's a man or woman, they would love to know our opinion on online dating and declaring your MS. I've been upfront and have had some very upsetting comments, almost as if I have to settle for less because I have MS. Any advice? And just to give my own circumstance, my wife, who I got married to, there a couple of months ago.
Congratulations.
Second marriage. I actually met her online, and it was one of these dating apps, and I declared it from the very beginning. But that is my nature. In my first marriage, again, on the first date that I had with, the first time I met my first wife, I told her I had MS. That has been my approach.
How you see, it goes back to competence, isn't it? If you feel competent with your MS, if you feel that you have authority and understand how you can manage it, you're going to be able to say, I just want to let you know, I'm going to be upfront with you. I have MS, but I manage it really well. And, I'm all these other qualities, rather than defining yourself as MS man or MS woman. It's hugely different. You'll be met differently by a person there. Are you allowing yourself, when you go to shut down, to come back, to approach and get back into what gives you mojo, what gives you vitality? And that might be doing the actual, like the last talk we had, might be doing the actual activity. It could be coaching. It could be walking up and down the swimming pool. It could be playing the last 4 holes of golf. It's all about, when we get stressed, we go into black or white, all or nothing. And when we talk to each other, if I want advice from you, Robert, you'll move me into a place of approach and curiosity. But if I'm on my own, I'll just end up in the bedroom or bathroom going in the same loop. The all or nothing thing. So it really does, it's again down to, there's so many people we'd all marry, no matter what disorder they have, because of the light in their eyes, or the interests they have, which makes them attractive.
And I think that's why, and this person obviously has had some issues with people making bad comments. To me, just disconnect from them. If that's the way they're going to be, there's no point in following on with that.
No.
And you cannot, it's a bit like when you go shopping for clothes. You're going to try on 5-10 different things, and you'll put them on, try them on, and they will look wrong, and you just discard them straight away. And I think when you're dealing with people online, a lot of the times they have a lower. They say things that they wouldn't say to you face to face. And it actually exposes the type of people that they are much quicker, and in many ways that's good, because you don't start building up a relationship with somebody who is going to be destructive.
There's a really interesting TED talk, which I watched the other night, where this woman who's a lawyer, I think, or an accountant or something, where she's looking for a relationship, and she gave herself certain rules, 5 rules, that they can't talk about sexuality, they can't talk about, looks, they can't talk about age and body and those type of things in this conversation. She went down to 5% of the people who initially responded to her, and she ended up living with one of the 5 people, because she had a certain list of close to people. The person has an interest, whether it makes money or not, to make a difference to her. But it's about those things which are attractive and you find attractive. The person has a sense of humor. They're warm. They have an interest in politics, or an interest in well-being of others, or whatever your list of interests you're kind of saying, okay, this person's a match for me in certain ways. Or maybe a lot of us will marry people with qualities that we don't have, which is great as well, because you can learn from in that. Yeah.
And to me, actually, that's it. It's the opposite that attracts me. I don't want to marry myself. I want to have, I want to have somebody that balances. And I find that certainly with my partner, she's much more energetic, much more outgoing, maybe, and moving all the time. And I actually feed off that. And I can't move as much, but I kind of feel like I'm moving by proxy when she's doing her thing.
Yes. Definitely. Yeah.
Now, another question here. I'd be interested in hearing about how you might deal with relationships with your clinicians. These can be problematic if patients are self-informed and to start to inquire and question what they are and aren't being told.
Yeah, that's one session we actually spend when I do groups, is a whole session on communication with professionals. And the first thing to do is if you're barking up the wrong tree, maybe go look for another tree. So if you feel that dismissed, not being listened to, not being met, it's probably time to move on and not spend too long in the communication and barking at the person for that they aren't meeting you at your certain needs. So we have to, like we talked earlier, become discerning and have good discernment about what I need from a certain person. Some people just want technicians and they're treating physicians. But when you've got an ongoing chronic condition, you need somebody who's got warmth, who has care, and who will keep an eye out for you and almost hold you inside themselves with at clinician level. But as we are clinicians, it's good to have things written down and to communicate clearly with us. The one defense I call, which is called the Spider-Man defense, is where a person would go fire about 50 different webs out at me, and not really, and come around towards the end of the session and say, well, this is what I'm really concerned about today. And I went, but wait a minute, we just dealt with 49 other things, and this is what you really are caring about. So it's about having an agenda sometimes if there's a time limit, and saying, okay, well, what's really your main concern? Because I really want to be able to listen. If a person's anxious, what I will do and you will do is we'll slow them right down and go, can we just stop you there? Literally, almost like a band person, just put the hand out, go, let's stop, just put a full stop there. Because I've just heard a lot of things, and I'll name the 7 things they've said. Is that all the things you said? What thing there is the most important? Because it's important to me that we really need to slow right down. Because a lot of the times when we go to clinicians, we get anxious. The just people like you, but being taught and learned certain things from books, and then over time, then they become expert at, referring you to different places, really, isn't it, or different things.
Sorry, you just broke up there a bit there, Jonathan. Sorry.
Oh, sorry.
Yeah.
Could move my. Is that better?
I know. I think it's the connection, the internet connection, maybe.
Okay. Yeah. So it's about slowing down and thinking about your key bits of information you need to impart to the person you're talking to, and to see if they meet you within that. If they aren't, either if you have a good relationship, you can say, look, I think, I've done that with clients. I say, look, I'm sorry, I think I missed you there in that session. And the person's gone, damn right you did. And I explain why. And that's so it's a healthy relationship, because we're not always perfect. If you're working in group situations or with nurses who are specialists and there's a group situation, it's impossible for a nurse or a person to take in more than one person at a time, really, because the way the brain focuses on one person. So as a group of people, to sit back and say, okay, I need to ask of time then. Irish, we aren't great at asking. We're great at undoing. It's where we assert ourselves and go, but I need time. And then we go back and go, well, I'm really sorry. Did I put yourself out there? Do this kind of almost, we take away our assertion. So we have to need to learn how to say things.
The interesting thing about dealing with clinicians, though, in Ireland is that we don't have a choice in one sense, that the neurologist that we have is the one that we have, or it's a different one every time. And we don't have that luxury of being able to say, well, I don't particularly like your manner. Switching is a big thing.
Huge thing.
If you're moving either GP or if you're moving to a different neurologist, you might have to wait for 2 or 3 years before you get to see that person. And that makes it even more difficult. And I'm just wondering, in that scenario, is it just writing down the questions? Is that the best way of dealing with it?
That is, I think, that's the same response, isn't it? Certainly living in Galway, there's certain towns I won't mention, but there's only one GP. And the locals survive through humor and go, did you hear that many F's and C's, he said, in the consultation? And the GP is like a vet out in the farm with the clients. But so they learn through laughing and telling the stories about how they interact with the GP as a way of coping. However, I do draw the line when the person's been given, particularly with women after difficult childbirth experiences, and the GP thinks they're depressed, when I think, no, they got post-traumatic stress disorder, they had a very traumatic birth. You have to say, look, at your GP isn't really listening to you, isn't hearing what you're saying. When that's happening, that means there's something wrong. And it could be that the GP's burnt out or the consultant's burnt out. And all you can do there is get your technical, instrumental needs met, as you're saying, Robert. It's here's what I need. Can I get this prescription and just get out?
Okay. Now, if I can look at some more questions here. Hi, I'm 70, live alone in Mayo. I am a widower for 10 years now. If I was to tell a lady friend that I have MS, when I met them first, they run a mile, and they've had MS since 2000. I would like to have a lady friend to go away for weekends together and maybe holiday away in the sun. Do you think that would be possible at that age, 70?
Of course, yeah. It goes back to what we said earlier. It's about, you see, I wondered if some people will view themselves through a dismissive eye. Do they view themselves as if, oh, that person has MS, and that almost their old self, if someone else had some kind of disorder, that they go, ooh, I'm not sure if I want to hang around with it. Is there a bit of shame that's been internalized into the person? If that's happened, then you need to externalize the shame and talk to a friend or write it out and say, what am I thinking about myself here? Because that becomes your filter to every person's eyes as you meet them. And every person's eyes has a warmth initially, and then they go, but oh, if they just knew my worms. Particularly, I work with a lot of people who have the with hepatitis C, with the the word, the Hep C infection. And they carried a huge stigma, and they still often do, particularly the older group, that what if I told someone about my hepatitis? How would they react? And 90% of people are totally loving and caring and go, well, this wasn't your fault, the state happened, or it happened during labor or something. But there's a proportion, about 1 in 4 of the people I work with, who carry that. They carry around the externally judgmental eye that they from themselves, and put it into other people's faces. It's amazing. So it becomes a self-fulfilling prophecy.
And if you find that right person, and I think this goes back to our last webinar about vitality, if you have that mojo or that vitality in you, I don't care what age you are, somebody's going to find you attractive because you have that sparkle in your eye, and you're interesting, and they will want to go on holiday with you because they just want to be with you.
Exactly.
And I think now this next question actually continues that. They said, don't worry, he was discarded instantly. Do all your bits work? And truth is, I have no idea. I've not been intimate since my diagnosis, and it's all new to me too. This goes back to your sexual function. And this is actually an important, to me anyway, an important part of relationships. I know the medication that I'm on, I tried for my bladder, that actually caused my penis and everything to go numb. I couldn't feel a thing. Now, because of my mobility issues and all that, I do have sexual problems. It's not, everything doesn't work right. So I use a pill, and that helps me. But there are times when no pill is going to work.
Yeah.
And I presume that the similar instance can happen for a woman too. I can't imagine
Yeah.
in that sense it would be that much different. But how do you overcome that sexual, if you cannot perform sexually, and that is an important part of your relationship?
Yeah.
How can you overcome that? How can you prevent yourselves becoming distant as a result?
Well, yeah. Where this can't be talked about in a relationship, couples will move into other areas of contempt. Okay. It'll become the socks you leave on the ground. It'll become, that you never clean the cooker. It'll become, something like that. Or you're always saying that you get headaches or you're getting pain or something. Friends, and we never do something. So the criticism and contempt occurs. But it might be that they're actually talking about a different thing. There might be the intimacy isn't there. We're not able to have sex anymore. What happened? Do you not find me attractive? And it's all about talking, I suppose, is the first thing. When I had my tongue procedure done in the summer, I had to sit down with my wife and go, look, I'm very frightened at the moment. I think I could die. I don't know what the results are going to be. They're going to remove about a thumb size from my tongue. And I'm very frightened by that. So literally for, I'd say, a good 6 weeks, there was nothing happening down there. And that's because when the fear system gets activated, until it turns off, the blood flow doesn't go to the vagina or to the penis. It just doesn't go there. There's no point. It's because your alarm system is going to start thinking about it. It's live, staying safe. So mess is in the middle of a flare. If it's coming back, if there's more symptoms coming out or less ability occurring, that's going to frighten you. And it's important to say to your partner, during these times, and I listened to Jonathan and Robert in the MS seminar, we get frightened and there's no point in trying to have sex or try to be physically intimate when we're frightened. It's just a silly thing to do because the blood, unless we start developing extra tubes to the area with bypasses, it's not going to occur. So to get our confidence back, when our fear comes down, first of all, and it might take multiple meetings with your consultant to make sure it's not, this is my final road, or will it be remitting, or what will happen? When the fear goes down, then we can start to think about, okay, having a conversation about, my fear is coming down a bit more. I'm getting more connection with my body, less numb. We might start to but at the same time, when that's there, one thing is about the rubbing and what I call affectionate sexuality. That sex starts a lot more before the actual final act. It's about the rubbing in the kitchen. It's about the little hugs. It's about the smile in the eyes. A kiss in the neck, all these very erotogenic things to do, but it's just saying I love you, isn't it? It's a bit like animals do. That we need to start at that level first. And what happens naturally then is people start to look at each other when it's almost think it's look, but having the conversation first. This is what happens with any chronic condition when there's fear based. When there's fear present, we can't get erections. We might be able to get erections, but we mightn't be able to maintain them. Because it's a very complex thing for a man particularly, and for women they'll become very dry, it'll be very painful, and they'll develop vaginismus where the vagina won't open, and that's a reason, because the body's frightened.
And it's almost like you're worried, you start and you're about to have sex, and then your head goes and starts saying, like, what if I can't finish, or what if I can't complete this, and then everything just goes blah. And it's and at that point you have to make a decision. Like there's no point in keep trying, because it's actually going to create frustration for both. But it's that, to maintain that intimacy. And I think that's interesting what you say about all those little touches, those little looks, those remarks, even the things that you do for the other person. That is all part of the experience of being in love and being together with somebody. So I think that we need to keep that going.
And to outgrow, kind of, particularly when you've got a chronic illness or a health condition, we have to outgrow our religious frameworks, where you have to allow yourself to really hate your partner if you love your partner.
Sorry, can you say that again? You just broke up, Jonathan.
You have to allow yourself to really, really hate your partner a few times a day, and to really love them a few times a day. Okay. That the normality of love is to hate and love in different sizes. Endearing, engrossing, ongoing love. It's and when we're able to articulate our frustration and to say this is part of my MS and not you, in a time which is good when you can meet the person, that's a really powerful communication. And if you do it with touch, it's just much nicer and it's gentle. If you've got a phone watch and if your heart beats over 100, it means you're in the grip and it's not a good time to talk to somebody. And that's what they find in all the relationship studies. When your heart rate is up, it means you're in fight or flight. Okay. And everyone will know it. They'll have one person in the couple who goes dominant. And what means is they literally get bigger. They start to use their fingers like this. And they're giving you it's all true what they're saying, but they'll go in a dominant way and the other partner goes submissive. And that means both are in fight or flight.
Yeah. And that's damaging. It's going to wreck the relationship. Okay. Another point here, my own experience with online dating, when I had relapsing remitting MS, I didn't put my MS on my profile and only disclosed the fact of my MS during the first date, which is something that I would have done. Yeah. The same with going for jobs. The fact of my MS is not on my CV, and I only disclosed the fact of my MS during the interview. And I actually would disclose my MS after I was offered the job. Mm-hmm. I don't disclose it beforehand. Yeah. Yeah.
Very important. And in fact, there was an article in American, I think the English psychology papers last month, and it was a psychologist applying for clinical training or counseling training. Do you talk about your own lived experience of depression or of anxiety? And it seems to be an unconscious bias in the courses about taking people on who have their own issues, which they've become resilient and so people are right to be a little bit. The whole thing about saying that state, I'm not,
Sorry, you're really breaking up there.
Yeah,
Jonathan. Yeah.
The state. I wonder if that's the best idea first. Because if would I say all my difficulties in life that the first date, or maybe the second or third date, or is there so the person gets, because are you starting to define putting the cart before the horse a little bit?
And I think this depends on each person's individual experience and the way they are as an individual, because we all have different things that make us attractive. And if you have that personality that people just want to be with, then it can be part of it. But I just feel that you have to really judge it depending on the other person. Okay. That might be too big of a shock to tell that person on the first date. Like, oh my God, this person's got an illness and what am I going to do?
Yeah, exactly. Okay. You're suddenly putting the person in a caregiver role. Yeah, the person's in a caregiver role immediately and you're eliciting concern. So whereas you want mojo, a shared interest and physical attraction and companionship kind of first before concern.
Yeah, absolutely.
The person starts to tilt their head at you, that means they're getting into, you poor thing,
Yeah, and that's the wrong way to have a relationship. It needs to be based on your personality, who you are, rather than, like I say, the color of my hair or the lack of hair, whatever.
And you don't have sex. Sorry for.
Pardon?
You don't have somebody you're sorry for.
Your signal is unfortunate.
I suppose it's sympathy. Sex isn't a good thing.
No, definitely not. No, it's the wrong basis. The next person here said, how do you find help with sexual problems from MS, and how to keep a reciprocal sexual or physical relationship when MS makes some things difficult? And I think we've answered that a little bit, what we mentioned before. But I also think you need to speak to your doctor and to ask them if there's anything that they can do to help.
Yeah, definitely. Certainly over-the-counter Viagra for men now. We need to keep an eye on, whether your heart rate, your blood pressure is okay. So get medical checkup. And for women, certainly lubricants really do help a lot, particularly if there's a tightness and tension there. And over the age of 50 in the menopause with women, they get drier anyway. But it's also being able to talk. It's kind of, you nearly have to get a board game or something for some people to get to talk about it, because they get so embarrassed and so they find it really difficult to talk about. So for a lot of women, in fact, we know that most women, more than penetration, will get orgasm through being touched in their vagina and the area in the clitoral hood, whereas for men it's more for more than penetration. Whereas for men, we need to open up about how we like to be touched, and to the conversation about, I don't like being touched on the shaft of my penis, it's more towards the top, and I like if we put some lubrication on. And having that conversation outside of it, during it, if it's playful, if you can be playful, that's fine. But outside, I'd say, what do you like? And that can save 20 years of misery and 20 years of doing the wrong thing.
Yes, absolutely. And it all, everything that we've discussed with you, Jonathan, over this whole series, it is all about communication at the end of the day. It's how you have those conversations, and when is the right time to have them, most suitable, and how can we understand the right time to have those conversations? And I know I'm repeating myself, but what is the right time and how to frame those conversations?
Well, I suppose one of the people, or maybe it's three in the relationship, will have to say, I've noticed that we aren't getting very far on our conversation about our affectionate ways of being affectionate, of having sex. When do you think would be a really good time for us to be able to take time out? Do we need to take time out? Do we need to plan it over the weekend? Do we need to go to a counselor? Do we need to, because this is really important. Do you think it's important? So in a way, you're inviting the person, are they curious? Now, if the person isn't curious, that can happen. That's a much more difficult road. If your partner is depressed, or through their MS has become depressed, that maybe you need to treat maybe an underlying depression or severe anxiety disorder first before we start looking at sex isn't the real issue here. So sometimes it's about treating because with depression, our libido goes. It's one of the first signs. With severe anxiety, you're so frightened, there's no blood flowing to that place in the first place, a bit like when you're suddenly having another flare of something. So but it's very easy, as you're saying earlier, is it that we're avoiding each other? Are we avoiding these things? Do we need to take time away? Do we need to send, if you've got children, do we need to send the kids off to the grandparents or somewhere so we can have this conversation? And remind yourselves that if you're not being affectionate in a sexual way, affectionate sexuality with each other, that's going to affect your children's belief in, how to be with other people. You're a model, you're a blueprint of how people work with each other. So it's important that we try it and that we model how to relate to other people for our children and for the people around.
And when you're having that conversation, I've read recently that it's actually better to actually say, this is going to be a difficult conversation.
Oh yeah.
To open it up in that way. But I also feel it is, for me, better to say, this is how I feel.
Yeah.
This is what's happening to me.
Yeah.
And not focus on talking about the other person.
Oh God, no, yeah.
Because I think when you start saying, oh, but you did this, or I wish you did that, or you should be doing something else.
Yeah.
I don't think that actually is constructive.
Yeah. So it's like a man saying, you turn away from me when I lose my erection, and you look sad, and it makes me feel terrible, and I think we should give up having sex. Versus saying, I really want to be close to you. I find you very attractive. I have a difficulty maintaining erections. I really want to work out with you how to be able to get it either through my erections, or is there something else I can do for you? And if I do lose my erection, what should we do that would make us both feel happier, even though I'm going to be frustrated?
And you are frustrated. I know.
Yeah.
And that has happened to me. And the frustration is there. Yeah. And my fear always is that my partner or my wife would feel that I'm not attracted to them anymore.
Yeah, exactly. Yeah.
But it is not that. It's a physical problem that I have. It's nothing to do. My brain is saying, God, I love you. I want to be with you.
Exactly. Yeah.
But my body is just not cooperating. And
you're so right. Yeah. And if you think about what you just said there, the message the person will hear is, I love you and I find you attractive. And the technical issue.
Pardon, can you?
I love you, I find you active, but we have technical issues.
And that's true.
You know,
and that's true.
That's what the person will hear.
I have one more question here because we're nearly at the end of this session, Jonathan. And as usual, they just fly by. Can you speak more about relationships with children and informing them about MS? For example, I currently do not have any symptoms affecting my functioning, so I don't look disabled, but when should I tell my children about my diagnosis? They're still only toddlers, but just to have in mind for the future. Thank you.
Wow. Well, that's really down to each different child will respond differently, and you get to know your children. Children will know and notice before you talk to. So it's about when they start to notice about what's happening to your arm, mammy. Well, why is your leg, why do you have to use your sticks today? So it's about explaining then, and very simple things, that mammy's wires don't connect so well today. So on those days, I use sticks, and that makes sense to the child. They go, okay, it makes sense. It's a bit like if your batteries go in your car, that you need to recharge them. Oh, okay, so I'm recharging my legs. Yeah. So there's different ways of saying it to children. Children are, it's more, again, putting our own eyes into the child's eyes is the difficulty here, because children are completely and utterly, no matter what's happening to you, they're loving and they're unconditional, like a dog. When they become angry, it's when they feel like they're being cut out in the relationship because of this somehow, and there's a secret or there's something dangerous going to happen to mommy or daddy.
And I think it's that openness. I think children respond actually pretty well to being told things, even though it's difficult, but you need to use the right language, I think.
Exactly. Because I remember during the summer when my operation was going on, was going to chemo there was oncologists and different people, and my daughter went, "Daddy, you're going to die." So that's a really good question. Let's look at this, and picked her up and run her and talk through all her fears and worries, and so no, I'm not sure, and I'll let you know and give her updates.
Very good. So, Jonathan, it is now we've hit the end of this webinar, and we've hit the end of this first progressive MS webinar series, and it has been an absolute fantastic journey, certainly for me.
Thank you.
Thank you very much for being part of this, Jonathan.
Thanks for the invite, Robert.
And I'm delighted to say that the MS Society, we're still talking about continuing this series on. And I would love if the people who are attending today could actually send us a message about other topics that you would like to discuss in this series, because it's for us, people with MS. And if we need to bring in the experts to answer the questions for us, that's what we shall do. And that's what that is my hope. This series could not be done without the help of Aidan Larkin and Aoife Kerwin, who have been there from the MS Society. They've made it happen. Also for Tom McCarthy, who is the PR guy within MS Ireland, who lets everybody know about these webinars. Thank you very much. And thank you for the people who have attended. This is for you. And the whole focus of this is to make you more resilient, to make you stronger in the face of this illness. And hopefully the content has given you something that you can do proactively to help make your life just that little bit better. So thank you very much, everybody. Goodbye.